Welcome back to the deep dive. Today, we are not sitting in an armchair philosophizing.
No, not at all.
We are walking straight into the trauma bay. We are walking into the resuscitation room, the place where the clock isn't just ticking, it's screaming at you.
Right.
We are talking about status epilepticus.
Hmm.
And honestly, just saying those two words makes my cortisol spike. You know the feeling I'm talking about.
I do.
You're standing at the foot of the bed.
Yeah.
The patient has been seizing for 12 minutes. The nurse is looking at you with that look that says, do something.
Yeah, that look.
The family's screaming in the hallway. And you are sweating because the patient is turning a shade of blue that human beings are simply not supposed to be.
Oh,
And you're asking yourself that one burning, panic-induced question. What do I do right now to stop the shaking?
it is a high-pressure environment, absolutely. It's controlled chaos. But here's the thing. Panic is the enemy of the neuron. While you were sweating the logistics, the IV line that won't thread, the jaw that won't open, I am looking at the molecular level. I am looking at receptors that are literally disappearing from the cell surface.
So we have to think smaller.
We need to move away from the throw everything at the wall and see what sticks method. We need to move toward a pathophysiology-driven precision strike. This isn't just about stopping the shaking, it is about saving the neural network.
Exactly. This is the Time is Brain protocol. We are doing a protocolized deep dive for the physicians in the trenches, ER docs, ICU docs, anyone who holds the pager. We have a stack of heavy-hitting sources today. The 2025 Guidelines on Clinical Management of Adult Status Epilepticus, transcripts from EM cases updates, and a comprehensive unified approach monograph.
A lot to get through.
We're going to be professional, we're going to be blunt about where we fail, and we're going to be darkly witty because, let's be honest, if you work in the ICU or the ER, that's your primary coping mechanism.
It is the only way to survive the shift. Our roadmap today is chronological. We are going from minute 0 all the way to minute 24 plus hours, the super refractory stage where the demons live.
I like that stage.
Nobody does. We will hit the 2025 guidelines, the ESET trial, and we are going to explain exactly why the drugs stop working if you wait too long.
So buckle up, let's unpack this.
Let's start with the definitions, because this has changed and it matters more than people think.
It definitely matters.
Yeah,
I remember the old days, and by old days I mean my residency, which wasn't that long ago, where the definition of status epilepticus was a seizure lasting 30 minutes.
30 minutes.
30 minutes. If I wait 30 minutes to call it an emergency, that brain is toast. It's essentially soup.
You are absolutely right to reject that old definition. That was based on old epidemiological data, not physiology. The sources are very clear on this. The paradigm has shifted entirely to a time-is-brain approach. We now operate on 2 time points, T1 and T2. This comes from the landmark work by Trinka and his group in 2015, and it is reinforced in the 2025 guidelines.
Okay, break down T1 for me. This is my pucker factor moment.
Precisely. T1 is 5 minutes. If a generalized tonic-clonic seizure lasts 5 minutes, the mechanisms that usually stop a seizure spontaneously have failed.
So the natural brakes are gone.
They're gone. Usually, your brain has inhibitory feedback loops that shut down a seizure in 60 to 90 seconds. If it goes to 5 minutes, those loops are broken. It is not going to stop on its own.
Wow.
And more importantly, pharmacological resistance is beginning. This is your treat now threshold.
So 5 minutes is the cutoff. If they are still seizing at 5 minutes, we are in status. We're treating, no, let's wait and see. No, maybe he's just working it out.
Correct. You treat. Then you have T2, which is 30 minutes.
The old definition.
The old definition, now repurposed as the injury threshold. By 30 minutes, we are seeing excitotoxic neuronal death, network injury, and systemic decompensation.
So that's when the real damage sets in.
That's when irreversible damage starts. The goal of everything we discussed today is to never let the patient reach T2. If you reach T2, you have already lost ground that you might not get back.
Okay, so T1 is 5 minutes, T2 is 30 minutes. That's the timeline. But we also need to know what we are looking at. We have different phenotypes or flavors of status, and they aren't all the movie-style shaking.
Right. And knowing the enemy is half the battle. The most obvious, and the one with the highest immediate threat to life, is generalized convulsive status epilepticus, or GCSE.
That's the one everyone pictures.
It's the rhythmic tonic-clonic jerking. You can't miss it. It's violent, it's noisy, and it's scary. That's the one that gets everyone running to the room.
But then you have the sneakier ones. Focal motor status, the twitching hand, the twitching face. It looks less dramatic.
It does.
The nurse might say, he's just twitching a bit. But that electrical storm can generalize at any second.
And then there's EPC, epilepsia partialis continua.
The endless twitch.
It's the unrelenting focal twitch. Just goes on and on. It's often structural, a tumor, a scar, or autoimmune. It's incredibly distressing to watch, but usually less systemically dangerous than the generalized form because the patient is often breathing and conscious.
Right, their ABCs are intact.
Usually. But then we have the silent killer.
NCSE. Non-convulsive status epilepticus. This is the one that keeps me up at night. The patient who seized, stopped shaking, but never woke up.
That is the comatose form. It's the subtle status. You look at the patient and they are just lying there. Maybe there is a tiny nystagmus or subtle finger twitch, but otherwise nothing.
But inside their head.
Inside, the brain is firing at 100 miles per hour. It is a continuous seizure that isn't manifesting with big convulsive movements.
And the other form is the wandering, confused patient. I see this a lot.
Exactly. The delirious grandmother who is actually in status. She's confused. She's picking at the air. She's not making sense. You might think it's a UTI or sundowning.
Right, you send off a urine and call it a day.
But it's a focal seizure affecting consciousness.
Yeah.
The sources emphasize that you cannot diagnose this without an EEG. If you have a patient who isn't waking up after a seizure or who is persistently altered without a clear cause, you have to suspect NCSE.
Get the EEG. Don't just assume delirium.
You have to.
And just a quick nod to the post-anoxic patient, the cardiac arrest survivor with the death twitch. How do we think about that?
Myoclonic status in post-anoxic injury, it is distinct. It often implies a poor prognosis because it signals deep cortical damage from the lack of oxygen.
So it's a bad sign.
It is a very bad sign. The guidelines say we still treat the seizures to see if there's an underlying recoverable rhythm, but distinguishing that from benign myoclonus, which is just a reflex, requires an EEG. You can't tell just by looking.
Okay, so we know what it is, and we know we have 5 minutes to act. Now, I need you to explain why time matters so much. Because in the ER, 5 minutes goes by in a blink.
It does.
Why can't I just take my time getting the IV? What is happening in the brain that makes speed so critical?
This is where it gets fascinating and honestly terrifying. There is a molecular shift that happens between minute 5 and minute 30. It explains why we fail. It comes down to receptor trafficking.
I love this part. It's like a heist movie happening on the cell membrane.
It is. Think about the synaptic membrane. In a normal state, you have GABA receptors sitting there. GABA is your inhibitory neurotransmitter. It's the brake pedal for the brain.
The off switch.
The off switch. Benzodiazepines, which are our first-line drugs, work by boosting GABA. They bind to the receptor, open the channel, let chloride in, and shut down the electricity.
Right, so I give Ativan, I hit the brakes, the car stops. Simple.
In a normal seizure, yes. But when a seizure persists, when you cross that T1 threshold of 5 minutes, massive amounts of GABA are released. The synapse is flooded.
Okay.
This triggers a process called clathrin-mediated endocytosis.
In plain English.
The receptors literally hide. The cell membrane pinches off, wraps the receptors in a little vesicle, and pulls them inside the cell. The sources quantify this. Within minutes, you lose up to 47% of your synaptic GABA receptors.
Almost half of them.
Almost half. They move from the surface to the interior of the neuron.
So I'm pushing lorazepam, which is floating around in the blood, looking for the GABA receptor.
But the receptor isn't there. You can't ring the doorbell if the house is gone. That is the mechanism of benzodiazepine resistance. The longer you wait, the fewer targets you have for your drugs.
So my drug is becoming less effective with every minute I wait.
Precisely. If you wait 20 minutes, giving a benzo is almost like giving water. It has nowhere to bind.
That is a terrifying thought. The brain is actively dismantling the very mechanism we use to save it. So while my brakes are disappearing, what about the gas pedal?
The gas pedal is floored. The NMDA receptors, these are the glutamatergic excitatory receptors, they actually upregulate. They move to the membrane.
Oh, come on.
So you have a loss of inhibition and a massive surge in excitation. It's a double hit. The brakes are gone and the accelerator is stuck down.
GABA goes missing, NMDA gets nasty.
That is the mnemonic hook. And there is one more layer. You want the real deep dive. Chloride dynamics.
Oh boy, here we go. Don't lose me here.
I won't. I'll keep it simple. There is a transporter called KCC2. Its job is to pump chloride out of the cell.
Okay.
This keeps the inside of the cell low in chloride, so when GABA opens the door, chloride rushes in to calm things down.
Okay. Chloride in equals calm. I got it.
But during prolonged seizures, KCC2 stops working. It downregulates, so chloride accumulates inside the cell.
Uh-oh.
So now, when GABA opens the channel, chloride doesn't rush in. The concentration gradient is gone. In fact, it can even rush out.
Wait, you're saying GABA can become excitatory? The brake pedal becomes another gas pedal?
Exactly. In late-stage status, your body's main inhibitor can flip and become an accelerator. This is why late status is so hard to treat. The physiology has completely inverted.
Okay, so the brain is cooking itself, but the body isn't doing much better. What's the systemic fallout? Because I'm looking at the monitor and everything is red.
It is a cascade. First, hyperthermia. You are physically cooking the brain. The muscle activity generates massive heat up to 41, 42 degrees Celsius.
Yeah, it's brain damage territory.
Absolutely. Then rhabdomyolysis, the muscles break down from the shaking, dumping myoglobin and killing the kidneys.
So now I have acute kidney injury on top of everything else.
Right. Acidosis lactate surges because the muscles are working anaerobically. The pH plummets. And aspiration pneumonia, which is a huge killer. The patient vomits, aspirates, and now you have lung failure on top of brain failure.
So the takeaway here is urgency. We are fighting a war on two fronts, the vanishing receptors in the brain and the collapsing physiology in the body.
Correct. Every second counts.
Let's move to the bedside. Minute 0. I'm walking into the room. Let's say it's the classic CT hallway scenario. The patient was sent for a scan. They started seizing on the table. There's no IV. The nurse is panicking, and transport is yelling for help. What are the first 10 minutes actions?
First, you have to breathe. If you panic, you lose. Then, ABCs. Airway positioning is crucial. Turn them lateral.
The recovery position.
The recovery position. Do not fight the jaw if it's clenched. You will break teeth, but suction what you can. Oxygen high flow is fine initially, but the guidelines warn against prolonged hyperoxia. Keep SATs 94-98%.
Access. I need lines. And this is where the fight happens.
2 large bore IVs. But here's the rule. If you fail, or if it takes more than 90 seconds, drill the IO.
The intraosseous line. I love the IO, but people are scared of it. They think it's barbaric.
It is not barbaric. It is life-saving. Intraosseous access is a valid, rapid route for status drugs. The marrow is a non-collapsible vein.
You can push anything through it.
Anything. If you are fumbling for a vein on a seizing patient for 5 minutes, you are letting their receptors disappear. Do not wait. Drill the shoulder, drill the tibia, get the drugs in.
And here's the one step I see people miss when it's chaotic. The don't ever forget step.
Glucose. You must check a fingerstick glucose immediately. Hypoglycemia is the great mimic. It looks exactly like status epilepticus.
And it's so easy to fix.
The easiest fix in the world. If they are below 60 milli-GDL, you treat with the D50 and thiamine.
But, and this is a big but, from the guidelines, do not delay the benzo while waiting for the glucometer.
Right. Do not stand there waiting for the readout. You can do both. Someone is checking the sugar. Someone is drawing up the meds. Treat concurrently.
Multitasking is key.
It is.
Also, get your monitors on. SpO2, ECG, and blood pressure. Expect the crash. Benzodiazepines drop blood pressure. Seizures spike it initially, but then it crashes. You need to see it coming.
And at TCO2 if you can.
Right, end title. And the stop rule.
Do not delay treatment for a CT scan. Do not delay for an EEG in the first 10 minutes. Treat first, scan later.
You cannot scan a seizing patient anyway? The motion artifact makes it useless. You're just irradiating a moving target.
Exactly. Treat the patient on the table if you have to. Stop the seizure, then figure out why it's happening.
All right, let's hit a micro recap. We are 10 minutes into this. Let's summarize minutes 0 to 10.
Okay, 5 key points. T1 is 5 minutes. If they cease for 5 minutes, treat immediately. Don't wait.
2.
The pathophysiology. GABA receptors internalize. They hide inside the cell. Benzodiazepines lose efficacy with every passing minute.
3.
Glucose. Check it immediately. Don't ever forget.
4.
Access. 2 IVs. If you fail in under 90 seconds, drill the IO.
And 5.
The mnemonic. GABA goes missing. NMDA gets nasty.
Perfect. Now we're at the emergent therapy phase. Minutes 0 to 5. We need to stop this seizure. We are reaching for the benzos.
Benzodiazepines are the undisputed first line, but the choice of agent and the dose matter immensely. This is where most cases are lost, right at the beginning.
Okay, let's talk about the menu. We have lorazepam, Ativan, midazolam, Versed, and diazepam, Valium. What is your go-to?
If I have an IV established, it is lorazepam.
Ativan.
The dose is 1 milligilograms. For a typical adult, that usually means a max of 4 milligrams per dose, but the guidelines allow repeating it.
And why lorazepam over diazepam? Diazepam is the classic movie drug.
Pharmacokinetics. Diazepam is very lipophilic. It shoots into the brain fast, which is great. It stops the seizure quickly.
That sounds good to me.
It is, but because it loves fat, it redistributes into the body fat just as fast. So the brain levels drop rapidly and the seizure can recur. We call that the redistribution effect.
So it works fast but doesn't last.
Exactly. Lorazepam is less lipophilic. It stays in the CNS longer. It has a longer duration of action in the brain.
But you have to push it slow, right?
Yes, it is viscous. Push over 2 minutes. Don't just slam it in.
Now, what if I don't have an IV? I'm in that CT hallway, the IO drill is missing, or I just can't get to the patient's arm.
Intramuscular midazolam. This is the Rampart study choice. It is incredibly effective.
Versed in the muscle.
Versus a deltoid in the thigh, wherever you can get it. The dose is 10 milligram IM for anyone over 40 kilograms.
10 milligrams, not 2, not 5.
10 milligrams. And this is where your tip comes in. Don't wimp out.
Seriously, I see this all the time. A 100-kilogram linebacker comes in seizing, and the resident orders 2 milligrams of Versed or 1 milligram of Ativan.
It's nothing.
That is homeopathy. That is a whisper. You are trying to stop an electrical storm. You need to shout at those receptors. Underdosing is the #1 failure point in early status management.
The sources agree. You must saturate the receptors while they are still on the membrane. If you underdose, you don't stop the trafficking. The receptors continue to hide. By the time you decide to give a second dose, you have fewer targets. You missed your window.
You get one shot, so make it a good one.
You really do.
What about diazepam? Is it ever the right choice?
It's an option if you don't have the others. 0.15, 0.2 millikilogram IV, max 10 milligram. But avoid rectal diazepam in adults if you can. Absorption is erratic and slow. It's really more of a pediatric formulation.
Okay, so I give you my 4 milligram of lorazepam or my 10 milligrams of midaz. The patient is still seizing. It's been 5 minutes.
You can repeat the benzo once, but only once.
Only once?
If they are still seizing after 2 doses of benzos, you are in established status epilepticus. Do not keep giving benzos. You will just stop their breathing without stopping the seizure. You need to move to stage 2 immediately.
Right. More benzos just leads to hypotension and respiratory arrest.
Yeah.
The seizure keeps going.
And you've created a second problem you have to manage.
Let's move to stage 2. This is the urgent control phase. Minutes 5 to 20. The benzos failed. We need a second-line anti-seizure medication, ASM.
The context here is the ESET trial. This was a massive study published in the NEJM that compared 3 drugs, levetiracetam, Keppra, fosphenytoin, and valproate.
And the winner was?
It was a tie.
A 3-way tie.
A 3-way tie. Roughly 50% efficacy for all of them. No clear winner.
Which is kind of depressing, isn't it? A coin flip. We give the drug, and half the time, it doesn't work.
It is humbling, but it simplifies things. Since they work about the same, you don't choose based on which is stronger. You choose based on side effects and patient factors.
So you choose based on what will kill this specific patient.
Exactly. That's the art of it.
So let's look at the menu. What's the default for most people?
Levetiracetam, Keppra, is the most common default because it is fast and easy. The dose is huge, 60 kilograms, max 4.5 grams.
60 milligrams. That is a massive bag. I feel like most people order 1 gram or maybe 2.
And that is underdosing. The ESET protocol uses 60 milligram. If you're going to use it right. The memory hook is the 60 kilogram patient gets a massive bag. Think about how big that dose really is.
What are the pros?
The pros. It sits nicely in a bag. It doesn't cause hemodynamic depression, and it has no drug interactions. You can give it to almost anyone. It's the safest bet if you don't know the patient's history.
And the cons?
Long-term behavioral changes, the famous Keppridge, and you need to adjust maintenance dosing for renal failure, but and this is key, you still give the full loading dose in renal failure. 1 dose won't kill the kidneys.
Okay, next option, fosphenytoin. This is the old school favorite. The smell of phenytoin is the smell of neurology.
It is. Fosphenytoin. Dose is 20 milligram PE, phenytoin equivalents kilogram, max 1.5 gram PE.
So fosphenytoin is just a prodrug for phenytoin, right?
Yeah.
Easier to give IV.
Exactly. Less risk of purple glove syndrome. But the safety pitfall here is cardiac. It is a sodium channel blocker. It can cause arrhythmias and hypotension if you push it too fast.
Right, it widens the QRS.
It does. You must monitor ECG and BP. The rate limit is 150 milligram PMN.
So if the patient have a heart block, bradycardia, or wide QRS.
Contraindicated, do not use it. You could stop the heart. It's a really important contraindication to remember.
Third option, valproate, dopacin.
Dose is 40 milligram kilogram, max 3 grams.
And its pitfalls.
This is a great drug for generalized epilepsy, maybe even slightly better than the others for genetic epilepsies, but it has a nasty safety profile in specific patients.
Pitfall.
Hepatotoxicity and hyperammonemia.
The liver.
Do not use this in liver failure, and absolutely avoid it in women of childbearing age if possible, due to teratogenicity.
Right. The risk of neural tube defects is high. If it's a young woman, reach for the Keppra.
That's the safest move. And if you suspect mitochondrial disease, avoid Valproate. It can be fatal in PLG mutations. If you have a kid or a young adult with liver issues and seizures, stay away from Valproate.
Are there any others on the menu? Any up-and-comers?
Lacosamide Vimpat is gaining traction. It's not in the original ESET3, but it's used. 400 milligram IV.
And its issue.
Watch the PR interval. It can cause heart block, just like phosphonetoin, so similar cardiac caution. And then there's phenobarbital.
Phenobarb. That's bringing out the big hammer.
It's a big hammer, 15-20 millijoule kilograms. It's great for alcohol withdrawal if your patient is an alcoholic. Phenobarb is king. It works on the GABA receptor, just like the benzos, so it makes sense.
Good.
But if you give a phenobarb load after a benzo load, expect to intubate. They will start breathing. The synergy on the respiratory drive is profound.
So, to summarize the selection logic, if they have liver failure,
Use Keppra.
if they have heart block,
Use Keppra or Valproate.
if they are pregnant,
Keppra.
if it's alcohol withdrawal.
Phenobarb is king, but be ready with the breathing tube. Precisely. Choose by patient factors. Don't just have a favorite, have a rationale.
Let's hit micro recap 2. Benzos in second line.
All right.
1.
Lorazepam, 4 milligram IV, 0.1 millig kilogram, push slow, do not underdose.
2.
Midazolam, 10 milligram IM if no IV access. Don't be afraid of the 10 milligram.
3.
Second line default. Levetiracetam, 60 milligrams, max 4.5 G is often the safest bet.
4.
Avoid Valproate in liver failure and pregnancy.
5.
Avoid phosphonetoin in cardiac conduction blocks.
All right, we are at minute 20. The nurse looks at you and says, "Doctor, he's still twitching." Or maybe the twitching stopped, but he's comatose and not waking up.
We are now in refractory status epilepticus, RSC. The definition, failure of a benzo, +1 second line ASM.
The pivot here is huge. We stop trying meds and we start taking over.
Correct. The patient is still twitching. Now what? Now we escalate to anesthetic coma.
Okay.
Step 1, RSI. You must intubate. Secure the airway. There's no more waiting.
And step 2.
Step 2, CEEG. Continuous EEG is mandatory.
Why is the EEG so critical now? I mean, I know he's seizing.
Because you are about to paralyze the patient for the intubation. Paralytic drugs stop the muscle movement, but they do nothing to the brain.
Right.
Paralysis hides the seizure. The brain is still frying, but the body is still. You need the EEG to see the enemy. Without it, you are flying blind.
You have no idea if your treatment is working.
None whatsoever.
So we intubate. What drugs are we using for the big guns? The anesthetic infusions. We need to keep them down.
We have 3 main players: propofol, midazolam, and ketamine.
Let's start with propofol. It's in every ICU. It's the milk of amnesia.
Propofol. You need a loading dose, 1 to 2 mg/kg, then an infusion. And the dose is high, 20-80 mg/kg.
That's a big dose.
It is. This is much higher than sedation doses. You are not sedating for comfort. You are sedating to suppress brain activity. You need to go high.
Pitfalls.
Hypotension. It will tank the pressure. It dilates the vessels and depresses the heart. You must have a norepinephrine, levofed, ready before you push the propofol.
Don't chase the pressure drop. Anticipate it.
Exactly. And long-term, pre-ISS, propofol infusion syndrome, acidosis, rhabdo, cardiac failure. It's rare but lethal. Monitor lactates and triglycerides. If the urine turns green, be worried.
Next up, midazolam infusion, a benzo drip.
Yes. Load 0.2 mg/kg, infusion 0.050, 0.4 mg/kg.
The problem here.
Pitfall, tachyphylaxis. It stops working after a day or so, the receptors get saturated, and it accumulates in renal failure. If your patient has bad kidneys, midazolam will stick around for days. The patient might not wake up for a week after you turn it off.
The prolonged coma.
Yes.
And my favorite, ketamine.
Yeah.
I feel like ketamine is the answer to everything these days.
In this case, it might be. This is where the physiology comes back. Remember, NMDA gets nasty.
Right, the gas pedal.
Ketamine is an NMDA antagonist. It hits the exact receptor that is upregulated in refractory status. It blocks the excitation. It is physiologically smart.
It's the rational choice.
It is. Dose, load 1 to 2 mg/kg. Infusion 1 to 5 mg/ERR. Pros. It stabilizes blood pressure. It doesn't drop it like propofol. It might even raise it. It's great for the hemodynamically unstable patient.
Is there a nuclear option? The break glass in case of emergency drug.
Pentobarbital or thiotental, the barbiturate coma.
Going deep.
This is total suppression. It wipes the EEG flat. but it causes profound hypotension. You will need vasopressors, maybe 2 of them. It is the last resort. It halts the gut. It suppresses the immune system. It is a big commitment.
So what is the target? We have the infusion running. What are we looking for on the EEG?
We want seizure suppression. No electrographic seizures. That's the first goal.
Just stop the seizures.
Some people aim for burst suppression, where the EEG is flatline with occasional blips of activity. That is a deeper coma. For refractory SE, seizure suppression is usually a goal. For super refractory, we might push for burst suppression.
And how long do we keep them down?
You maintain this for 24 to 48 hours before you even try to wean. Do not wake them up in 2 hours to check a neuroexam. You will just bring the seizure back. You need to let the brain rest and reset.
Micro recap 3, the refractory stage.
Let's do it.
First point.
Definition: failed benzo plus second-line ASM
Second.
action, intubate plus continuous EEG, non-negotiable.
Third.
Propofol, high dose, watch for pris and hypotension, have pressors ready.
Fourth.
Ketamine. Targets NMDA receptors physiologically rational for late status.
And fifth.
Target, stop electrographic seizures, not just movement. Keep them down for at least 24 hours.
Okay, we are deep in the woods now. It's been 24 hours. The patient is in the ICU. We try to wean the propofol and the seizures come back, or they never stop.
This is super refractory status epilepticus, SRSE. The mortality here is high, approaching 30–50%. This is a very dangerous place to be.
What is left on the menu? We've used the big drugs, we've used the big drips.
The escalation menu gets creative and the evidence gets a bit thinner.
Right, we're off the map.
We're moving into case series and expert opinion. First, ketamine. If you haven't started it yet, start it now. Second, the ketogenic diet.
The diet, like bacon and butter. I thought that was for weight loss.
It works for epilepsy. We use a formula via NG tube that is high fat, low carb, a 4.1 ratio. It causes a metabolic shift. Ketosis stabilizes neuronal membranes.
How does that work?
It alters the energetics of the neuron. It's complex, but it's surprisingly effective in children and increasingly used in adults for SRSE.
What else?
Inhaled anesthetics. Isoflurane. You need an anesthesia machine in the ICU. It works, but it's hard to sustain logistically. And immunotherapy. If this is autoimmune, you need steroids, IVIG, plasma exchange.
And the really last-ditch effort.
Neuromodulation, or ECT, electroconvulsive therapy, the reset button.
You're talking about shocking the brain to stop the seizing.
It sounds barbaric, but it can work. Evidence is weaker here, mostly case series. But when you are in SRSE, you are fighting for life. ECT can terminate the status by forcing a refractory period in the neurons. It's a valid consideration.
Let's pivot to diagnostics. We talked about treating first, scanning later. But eventually we need to know why this is happening. We can't just suppress the symptom forever.
Right. The hunt for the cause begins as soon as the patient is stabilized. Timing is everything.
So CT scan first.
CT head. Get it after stabilization, post-intubation usually, to rule out a bleed, tumor, or massive stroke. The big obvious things.
Then MRI later.
MRI. You get this later. Once they are stable, it looks for subtle encephalitis, cortical dysplasia, or hippocampal changes that the CT would miss.
And the EEG strategy. We mentioned spot versus continuous.
Spot EEG is a snapshot. If it's normal, it helps rule out NCSE, but if you catch them between seizures, it might be misleading.
So it's not very sensitive.
Right. Continuous EEG, CEEG, is essential for paralyzed patients, and the Salzburg criteria are the gold standard for diagnosing NCSE on that EEG.
What's the gist of that?
It is complex, but essentially you need a rhythmic pattern at a frequency 2.5 hertz or a pattern that fluctuates with intervention, like a benzo trial, to confidently call it a seizure. It helps separate true seizures from other weird-looking brainwaves.
Pitfall alert.
Yeah.
Drug-confounded patterns.
Yes. This is a huge trap. Drugs like cefepime or piperacillin tazobactam can cause triphasic waves that look like seizures but are actually toxicity.
I've seen that with cefepime.
It's common. If you keep adding seizure meds, you treat the EEG but kill the kidneys. You need to stop the antibiotic. If the seizures stop when you stop the antibiotic, it wasn't a seizure.
Lumbar puncture. When do I do the LP?
Trigger it if there is fever, unknown etiology, immunocompromised state, or suspicion of autoimmune encephalitis. Look for that infection or inflammation.
This brings us to the Hunt Now panel. While the propofol is running, I need to find the cause. What are the never-miss etiologies? The things that, if I miss, the patient dies no matter how much propofol I give.
Number 1, CNS infection. Specifically, HSV encephalitis. If there is fever or temporal lobe changes on imaging, start Empirica Zyclover immediately. Do not wait for the PCR from the spinal fluid. It takes too long.
Okay, what's next?
Autoimmune NORS. New onset refractory SC. This is the young, healthy patient, maybe a viral prodrome, flu-like symptoms, then explosive seizures.
And the treatment.
Treat with steroids of Ig early. Don't wait for the antibody panel. It takes weeks. If the story fits, you treat empirically.
Toxins.
INH, isoniazid, overdose. This is the TB patient. The antidote is paradoxin, vitamin B6, dose, 5 grams 40, gram for gram with the INH, if known, otherwise 5G. The seizures will not stop without it.
That's a classic board question.
It is. An alcohol withdrawal. Needs phenobarbital or massive benzos.
Metabolic.
The simple stuff first. Hyponatremia. If the sodium is 110, give 3% hypertonic saline. Raise it acutely. Hypoglycemia. D50.
And the special cases.
Eclampsia. Pregnant or postpartum. This is a specific protocol. The antidote is magnesium sulfate, 4 to 6 gram IV load. Benzos often fail here. You need the mag.
Micro recap 4. Diagnostics and etiology.
Let's do it. Infection. Acyclovir early if suspicious.
Yeah.
Toxin. Pyridoxine B6 for INH toxicity.
3.
Eclampsia. Magnesium sulfate.
4.
Autoimmune. Consider immune suppression for Norse.
And 5.
EEG. Don't trust the physical exam in a paralyzed patient. Watch out for C-Pime toxicity.
We are nearing the end, but we have to talk about how the treatment itself can hurt the patient. Complications. We are flooding them with drugs.
This is critical. We mentioned PRIS, propofol infusion syndrome, monitor lactate, CK, creatine kinase, and triglycerides. If the heart starts failing and the urine turns green, stop the propofol immediately. It has a high mortality.
Rhabdomyolysis.
High seizure burden equals muscle breakdown. Myoglobin kills kidneys. Hydrate aggressively. Check the CK. If it's 50,000, you have a problem.
Hemodynamics.
Expect hypotension. The benzos do it. The propofol does it. The phenobarb does it.
What's the action?
Action. Have norepinephrine ready. Do not let the MAP drop below 65. The brain needs blood flow. If you stop the seizure but starve the brain of blood, you haven't saved anything.
And aspiration.
Early airway protection saves lungs. If they vomited during the seizure, treat for pneumonitis pneumonia.
All right. We have covered a massive amount of ground. We have gone from the doorway, through the receptor internalization, all the way to the ICU ventilator. It's time for the outro. The mega recap.
Let's pull it all together into a single algorithm.
I'll do the speed run.
Yeah.
You're at the bedside. The clock starts now.
Go.
5 minutes. ABCs, glucose check, IVIO access, lorazepam 4 milligram IM, or Maydaz 10 milligram IM.
End.
5:20 minute. Seizure continues. Give levetiracetam 60 milligram kilogram, or valproate phosphine based on the patient.
Still seizing.
20-40 minutes. Refractory. Intubate. Start propofol ketamine infusion, CEEG.
And beyond.
24HR super refractory. You're calling for help, but you're thinking ketogenic diet, immunotherapy, isoflurane.
Perfect. Now, the top 15 ways we lose this case. These are the pitfalls to avoid.
Okay, let's list them. 1. Underdosing benzos. Homeopathy. Give the full dose.
2. Delaying the second dose of benzos or giving a third or fourth.
3. Delaying intubation when the airway is threatened.
4. Missing hypoglycemia. Don't ever forget glucose.
5. Forgetting INH pyridoxine in the TB patient.
6. Missing NCSE in the confused grandma.
7. Giving valproate to a liver failure patient.
8. Giving phosphonatoin to a heart block patient.
9. Ignoring hypotension pressors must be ready.
10. Causing PRIS by running propofol too high for too long.
11. Failing to check sodium. Hyponatremia.
12. Thinking the seizure stopped just because the shaking stopped. Paralysis hides the seizure.
13. Not checking for pregnancy. Eclampsia requires MAG.
14. Delaying second-line meds to see if the benzo works.
And 15. Not starting the clock at onset. Time is brain.
Excellent list. Now, rapid-fire board questions. I ask, you answer. Source faithful.
Hit me.
Q1, drug for INH toxicity.
Pyridoxine, vitamin B6, 5G1.
Q2, first line for eclampsia.
Magnesium sulfate.
Q3, max dose of levetiracetam loading.
4.5 grams.
Q4, mechanism of benzo resistance in SE.
GABA receptor internalization, trafficking, and NMDA upregulation.
Q5, second-line agent contraindicated in heart block.
Phosphonatoin and lacosamide 2.
Q6, ESET trial conclusion.
Levetiracetam, valproate, and phosphonatoin are roughly equivalent in efficacy, about 50%.
Q7, antidote for valproate-induced hyperammonemia.
L-carnitine.
Q8, diagnosis of NCSE requires what?
Salzburg criteria on EEG.
You passed.
I feel like I just ran a marathon. My brain is full.
You essentially did, but remember the core message. It's not about memorizing a list. It's about understanding the physiology so you can make the right move when the pressure's on.
Set your timer. Don't panic. follow the physiology.
Save the neurons, treat the cause.
This has been the Deep Dive on status epilepticus. Go save some brains.